So I'm going to be going through some slides here on how I do transperineal prostate biopsy under local anesthesia, which is done in the office setting, using a few unique partner technologies, in particular 3D ultrasound, using the KOELIS Trinity system, along with the PrecisionPoint transperineal access system. I realize that the thing that's probably most new to the audience is this concept of doing it under local anesthesia. So I'm going to spend quite a few slides on the middle section of the talk on how I go about doing this, and hopefully, after seeing this, you could be adventurous and try it. Just by show of hands, who's doing transperineal biopsies in the audience? And how many are doing it under local versus anesthesia? So let's show your hands for anesthesia. Okay. And how about local? Okay, so mixed crowd. Okay, so why transperineal prostate biopsy? Well, as you know, sort of the tried and true method for performing prostate biopsy has been via the transrectal approach, and it's been done like this since, let's say, the mid to late 80s up until actually current day. The majority of urologists, at least in the United States, still perform transrectal prostate biopsy. And of course, the problem with this technique, while it is very easy to both visualize and access the prostate, and because you're above the dentate line, patients are rather insensate with the exception of the prostate itself. The problem is that the needle passes alongside the probe, puncturing the rectal mucosa, taking with it stool, or potentially taking with it stool and bacteria particles, leading to the concerns with respect to infectious complications. So this is from Michael Liss's paper on behalf of the American Urological Association in 2017, where they did more or less a systematic review looking at the risk of complications from prostate biopsy. And they found that the risk of infection, at least at this point in time, was about 5 to 7%, with 1 to 3% of patients actually being hospitalized because of sepsis as a result of this. And when we think about this from a number standpoint, this is a ton of patients who are going to actually have these complications. It's been estimated that in the United States, 1.97 million prostate biopsies are being performed, and in Europe, that number is 1.84 million. So when we think about just sepsis alone, and we give it a lower bound of, say, 1%, in the United States, that's 20,000 patients per year, and about 18,000 in Europe. And then, of course, if that rate goes as high as the Liss paper suggests, this is, really a significant number of patients. And the cost of sepsis is very consequential to the American healthcare system. This is a review that myself and Jim Hugh put together with a medical student, Michael Gross, and we looked at the cost in the literature associated with urosepsis. And even at the cheapest, it's about $3,000 for a patient to be admitted for urosepsis. So you're talking tens of millions of dollars associated with this complication. So cutting to the chase, there is an alternative approach for performing prostate biopsy, and that's through the transperineal route, which is percutaneous. So the needle's actually going through the skin between the scrotum and the rectum, avoiding the stool. Now, it is true that an ultrasound probe still gets placed in the rectum, allowing you to visualize the prostate, but because this needle is never in contact with stool, it's, at least in theory, a safer procedure. And it's more than a theory at this point. It has been clearly demonstrated in the literature to be associated with improved infectious complication outcomes. This is a randomized controlled trial that I was fortunate enough to be a part of. Jim Hugh wrote for an R01 with Andrew Vickers and got it to support this trial, where patients were randomized to transperineal prostate biopsy without antibiotics whatsoever versus transrectal prostate biopsy with antibiotics directed on the basis of a quinolone resistance rectal culture. There was an early version of this trial that was known as the PREVENT trial, published in European Urology, and then with further accrual, we just republished it in JAMA Oncology, and we found 0 grade 2 or above infections in the transperineal route, despite barely giving any doses, if any, of antibiotics, versus a rate of 1.6% in the transrectal group, making it statistically significant. So just think about that from a sort of logistics standpoint, health economic standpoint, the decrease in the number of infections aside, every single one of these patients required a rectal culture. You had to mail them a kit or give them a kit. They had to get it back to you. It had to make it to the lab. It had a result. Someone had to follow up those results. Someone had to, give them the appropriate antibiotics as a result of it. Versus this, hey, just show up on Tuesday for your biopsy. So that's how I do it without any antibiotics whatsoever. And I do so using the KOELIS Trinity biopsy platform, which is a 3D ultrasound-based system. KOELIS has been generous enough to be a sponsor of this meeting. And later on today in the hall, you should go check out their machine. But what I'm about to show you with respect to the use of local anesthesia, as well as the PrecisionPoint Transperineal Access System, you don't have to use the KOELIS system for. This is just my system of choice. So just to familiarize you, because I am going to show you different video clips of how I actually go about doing this, I wanted to just walk you through how the KOELIS Trinity system works. That way you don't get lost in the videos. So this is a side-fire ultrasound probe that has a motorized head within it. So you don't actually have to rotate the probe to get images of the prostate. You simply put it in the rectum and hold the probe there, press a pedal, and then the ultrasound probe head then moves like this about 200, well, it depends on how many degrees you set it for, but on average about 210 degrees from left to right, taking a full continuous series of images of the prostate, which could then be reconstructed in 3 planes of view: axial, coronal, and then they're natively acquired in the sagittal view. Okay. Once you've acquired your image, you then segment it, and this is very similar for those of you who use, say, the BK Fusion system or the UroNav system. You're familiar with this concept of segmenting the prostate. Prior to the procedure, you've segmented your MRI, or your radiologist has, and then you perform an elastic fusion step, which brings those two images together. Now, there is no sort of like live tracking with the target on the screen. Rather, what you do is you go ahead and you point your ultrasound probe at where you believe the target to be. You step on the pedal again, and you take an updated sweep of the prostate. And then automatic, using computer vision, ultrasound to ultrasound fusion occurs, showing you where you're presently located versus where you originally were at the time of your fusion. And so long as you don't move your ultrasound probe after obtaining that sweep, if you like your position, all you have to do is then fire your needle, reacquire your image to record exactly where your needle was, and then in time you populate what's known as a 3D reference volume with all your different needle locations. So I pair the KOELIS Trinity system with the PrecisionPoint Transperineal Access System, which was invented by my very good friend, Dr. Matt Alloway, who's a private practice urologist in Cumberland, Maryland, and amazingly, through inventing this device, has revolutionized, I feel, the field of urology. So let me just show you, using the KOELIS system, what it's like to prep the MRI images, and then I'll talk more about the PrecisionPoint system. So basically, either using a web-based software or a dedicated workstation called MR Draw, you could just go through and you could drop little points all around the periphery of your prostate here on the MRI to gain a segmentation of the prostate itself. And then you go ahead and do the same by dropping a sphere and then contouring to the lesion. Now, I personally like to do this myself. I don't have the radiologist do it, and I do it for 2 reasons. There's a sort of I think a patient-centric reason, and then a Dr. Gorin-centric reason. So the patient-centric lesion is the fact that I am, intimately aware of where this lesion is. It's not a black box to me. I don't just simply open up the images onto the biopsy system and then sort of point and shoot. By me actually contouring the prostate and contouring the lesion, I know every nook and cranny of this prostate, so that way, when it's time to do the biopsy, I can land my needle exactly in the right spot. From a more, I would say doctor-centric point of view, you get paid for this service. You could bill for it a few days prior to the procedure. There's a CPT code that we use. It's 3D contouring of the prostate on a dedicated workstation, and the urologist gets paid about $80 for doing so. So, how do I know where the lesions are to contour them? And I get a lot of pushback from urologists I train on this procedure saying, I can't accept the medical legal liability of contouring these images myself. Well, I think that's very easily overcome through the use of key images. Probably all of your radiologists already drop into the PACS system a key image pointing to where your lesion is, right? You know the boundaries of the prostate. You have no problem contouring that. So basically, all you're doing here is dropping an orb right on top of the area that the radiologist has already pointed to in your PACS system of that key image. You scroll up or down a few slices, extend that so that you're covering the entire area, and that key image almost always tells you what series you're looking at and what slice number, and you just sort of find that exact slice on your workstation. It's easy peasy. So again, I use the PrecisionPoint Transperineal Access System. So this is a freehand-based approach. So the access system is composed of three main components. There's an access cannula or an access trocar, a rail clamp subassembly, and then a needle guide with 5 aperture holes. The rail clamp assembly gets connected to the probe like so. The needle guide then goes up and down the rails of that clamp assembly, and then the access needle goes through one of those aperture holes. Now, when using this device in conjunction with KOELIS, you have to secure it to the probe somehow because the clamp isn't perfect at getting it onto the probe. And so what I was showing in that image back here is that you could very easily do that. Hold on, let it go back by just applying a piece of Coban around the probe. Or if you want sort of a more purpose-built solution, I have made this 3D printed adapter. It's non-sterile, but it doesn't need to be because you're not actually touching it during the case. That we just put right onto the probe here. And if you go to my website, you could download the STL file for it. You could send it to a 3D printing company and get like 500 of them made for $10. Okay, so that's the access system, and I'm going to go through in a bit more detail with further videos how you actually use that when performing the biopsy. But now I'm going to get into the portion of the talk which I think is of greatest interest to folks, and that's how am I doing this under local anesthesia. So I'll start by reminding everyone of the anatomy of the nerve innervation to the perineum and the prostate itself. So right underneath the ischial tuberosity of the pelvic bones, you have Alcock's canal, and through that emerges the pudendal nerve. The pudendal nerve then splays out to have the inferior anal nerves, the superficial and the deep branches of the perineal nerve. Okay, so you have to somehow be able to block all these peripheral nerves and or block the trunk of the pudendal nerve in order for the patient to be able to tolerate you going through the skin, the soft tissue, the levator ani muscle complex to tolerate this procedure under local. In addition to that, you have to numb the prostate itself, which is not innervated by the pudendal nerve, but rather the pelvic plexus. So I would say the most commonly used method for numbing the nerves the branches of the pudendal nerve for doing this under local anesthesia is what's called the periapical triangle block. So imagine, if you will, a triangle that's bounded by the levator ani muscle complex, the external anal sphincter, and then the rhabdosphincter of the urethra. That triangle, imagine it as a 3D column all the way out to the skin. What you're essentially doing is under ultrasound guidance, first numbing the skin and then numbing this entire column on the left side of the prostate and then the right side of the prostate. Then to numb the prostate itself, you're going to do what's called a prostate apex block. So once you've been able to numb those structures, which again are in this column of tissue right here, leading all the way up to the endopelvic fascia, you're then going to pop your needle through the endopelvic fascia and inject your lidocaine so that it starts bathing the prostate itself. And by bathing the prostate, that'll be more than sufficient for getting the prostate numb in doing this procedure. So how do I do it? I do a combination of approaches. I attempt to do a pudendal nerve block, and I'll show you a video in a moment of how I do it, because I want to have my best chance at being able to block all the different fibers that splay out into the region. I also do my periapical triangle block because there is a reasonable probability that the pudendal nerve block doesn't take and then I perform the prostate apex block. But the real secret is in how much lidocaine I use in a special preparation that I have termed the Gallagher solution. So I'm using 1 to 200 milliliters of a very dilute and buffered form of lidocaine. It's buffered to a pH of 7.4 with a near physiologic osmolarity of 298 milliosmoles per liter at a concentration of 0.11%. And I'm going to go through in detail how we came to develop that. So why buffer and dilute lidocaine? So thinking back to your days in chemistry, lidocaine is a weak base. When it's in its base form, it's ionized, and so I'm sorry, yeah, when it's in its basic form, it's ionized, and so it's able to be an aqueous solution. It won't fall, it won't crash out of solution. So it's stored on the shelf at an acidic pH of about 5.5. However, lidocaine needs to first get through the bilipid cell membrane in order to exert its effects on the voltage-gated sodium channels. So when you inject unbuffered lidocaine, what first happens is it gives up its proton in the interstitium so that it's in its non-ionized form. Then it goes across the cell membrane where it then picks up a proton again, and only then can it block the voltage-gated sodium channels. So a very small percentage of the lidocaine that you're injecting is already in this neutral form, ready to go across the cell membrane. So this step takes time and it has to occur. In addition to that, because the pH of the lidocaine that you're injecting is only 5.5, it burns a lot when you inject the patient with that medication. However, if we use buffered lidocaine, a larger percentage of the lidocaine molecules are now missing their proton, so they're right out of the syringe, ready to cross the cell membrane and exert their effect on the voltage-gated sodium channel. And I'll further get into why we dilute it in just a moment here. So, what is the recipe for the so-called Gallagher solution? Well, I take 250 milliliters of lactated ringers, 5 mils of 8.4% sodium bicarb, and 15 mils of 2% lidocaine. And if you go through all the stoichiometry and employ the Henderson-Hasselbalch equation and so forth, you come to a lidocaine solution of 0.11% at a physiologic osmolarity and pH. So when you inject this into the patient, it shouldn't burn because it's the same pH as the serum, and it shouldn't irritate the tissue because it's the same osmolarity. But how are we able to do this at such a small concentration? Well, it's because of the number of neutral charged lidocaine molecules that are injected per mil. Because we're no longer injecting it at a 5.5 or a solution of 5.5 or a pH of 6, many more molecules now are in that on non-ionized form and are ready to go to work right away. Okay, so you can see here with 2% lidocaine, again, for the purpose of these calculations, I used a pH of 6. The companies have all brought it up to an osmolarity of 300. That way, it doesn't irritate that much other than the burn. But the number of neutral charged lidocaine molecules in 1 mil is 2.76 times 10 to the 17th. But because of the safety limits associated with lidocaine, you could only inject patients with a total of 16 mLs of 2% lidocaine or 32 mLs of 1% lidocaine. After you account for the differences caused by the pH in terms of the number of neutral non-ionized molecules, you're able to actually achieve the exact same concentration of neutral charged molecules, if not a little bit more, by bringing it down all the way to 0.11%, allowing you to use a huge volume of solution to allow you to block the pudendal nerve and the peripheral nerve fibers. So it burns less, more potent, yeah, maybe by a tiny bit, and there's a ton more to use. And that's really the secret sauce to being able to do this under local, in my opinion. Now, how do you inject such large volumes? Well, we use basically a repeating syringe. This is the one from Boston Scientific, but there's an even cheaper one from USA Vein Solutions. It's like $9 per syringe or something like that. We mix up the solution in a 250 ml bag. So basically you inject and then the syringe just sort of bounces back and refills itself back up. And in a given case, you could use 100 to 200 mils, whatever it is you need to get the patient numb. So the steps for the local anesthesia administration, I first infiltrate the areas of skin overlying the ischial tuberosities. I then infiltrate the areas of skin where the access needle will eventually be engaged at the time of biopsy, and you'll see that in the video in just a moment. I bilaterally block the pudendal nerves under Doppler ultrasound as they arise from Alcock's canal. And then I bilaterally infiltrate the subcutaneous tissue, the pelvic floor muscles, and the apical periprostatic space, essentially doing the combined steps of that triangle block and the apical block. So to show you what it looks like to do the pudendal nerve block, basically I put the ultrasound probe in and then identify the ischial tuberosity on ultrasound. If you look at the sagittal image here, you could see this is the ischial tuberosity here. Then I put on color Doppler to help me find the artery and vein as they're coming out underneath the ischial tuberosity. So this is basically Alcock's canal here. And then under ultrasound guidance, I simply take my needle and I'll pass it until I get just right outside of the artery and vein. And then I'll inject about 20 to 30 mils of the dilute buffered solution right into the space containing the nerve. And then, so long as I'm able to actually get it into the nerve sheath and not get it into the artery or vein, again, even if I did, it's probably, we know it's safe because of how dilute the solution is. I'm able to get a pretty dense block right from the get-go there. And the same steps are followed on the contralateral side. So next up, I administer the local anesthetic to the skin where my access needle is going to puncture, and then to that triangular column. So in this video here, you can see my hands with the PrecisionPoint Transperineal access system. I'm basically finding the lateral 1/3 of the prostate on either side, and then I'm marking the skin to help me visualize things. Then I'll simply bring my needle in and go ahead and raise a wheel of maybe about 10 cc's of lidocaine on both sides. So we're already up to maybe about 60, 80 mils of the lidocaine solution. And then I'll pass my needle under ultrasound guidance and infiltrate that triangular column, the soft tissue. You'll see the needle, it punctures right into the levator ani muscle complex and just, fills it with the lidocaine solution. Then I'm going to puncture underneath the endopelvic fascia here and inject more solution to bathe the prostate itself. So maybe another 20, 30 mils on one side, another 20, 30 mils on the other side. And before long, I've basically consumed, 150 to 200 mils of the solution. So those are the steps to getting the patient numb, and we've been able to show that we could get maximal pain scores in the range of, I would say, 2.5 to 3.5. We published this in the Gold Journal, showing that this basically brings pain scores with this procedure down to exactly what we see with the transrectal approach. And I don't think anyone would disagree that that procedure can't be readily done under local anesthesia. So once I've gone ahead and numbed the patient, then I'm off to performing the biopsy following this workflow. So the first step here is to take a reference ultrasound acquisition. So the probe's in the rectum. It's taking a 3D sweep of the gland. So the probe, I'm not moving it, but the motorized head is. Then I contour the prostate, making a 3D reference volume of it. So once I've made that 3D reference volume, I perform elastic registration between the ultrasound and the MRI. And we confirm that with a checkerboard view showing the ultrasound in the top left and bottom right and the MRI in the bottom left and the upper right. And you could see that the contours of those two structures are perfectly aligned with one another. So I know I'm ready to begin. Next up, I go ahead and insert the access trocar into the area of skin that I've numbed. So you just simply push that access trocar down the rails and goes into the skin. You can see this patient is awake. They didn't move at all upon doing that. And then through that access point, I'm then able to biopsy the whole either left or right side of the prostate. And what this video is very simply showing is if you look at the central portion here with the live ultrasound, I'm simply lining up with where I think my lesion is. I take an updated reference ultrasound. If the image is indeed aligned with the target, I'll then see it appear here. And then I just simply pass my needle in, fire, and collect my tissue. So, yep, I'm in the correct view. So now it's just a matter of putting the needle in, hitting fire, doing an updated 3D ultrasound, and you'll see my needle, as where it actually was, is going to be updated on this image here. You could see I was a little bit lateral there, but overall very accurate recording. And then you just do this in a templated fashion to capture, cores from the entire peripheral zone of the prostate. And you could see that your reference ultrasound, your reference volume rather, gets populated with those cores as you go. So I get asked a lot of questions about what template I use for performing transperineal prostate biopsy. I use what's called the 10 sector technique, which was popularized again by Dr. Alloway at Perineologic. And he did these very careful studies where he did a full 20 core biopsy and then looked to see the yield versus 18 cores versus 16 cores and so forth, and found that really the optimal number is 20 cores, where you basically break the prostate up into 5 sectors on either side. You're basically going throughout the entire peripheral zone of the prostate and then anteriorly up through the anterior fibromuscular stroma. And then to account for the length of the prostate in large prostates, you're doing basically stack cores where here from the apex to mid, you're going, apex just to the mid of the gland, and then you're accounting for that length by then deploying a second core from the mid prostate to the base. So there you have 2 cores stacked on top of one another like that, giving you total of 20 cores. In small prostates, you could actually omit these and just do a 16 core biopsy, and I'd probably do that about 50% of the time. So why this template? Well, if we look at these topographic mapping studies of where prostate cancer is found in the gland, this is a paper where I think they took like 300 glands and they mapped out where the prostate cancer was and then fused them all together to make this heat map. And you could see prostate cancer very nicely follows the peripheral zone, almost entirely sparing the transition zone, with the exception of the anterior aspect of the prostate, in particular at the apex of the gland, not so much at the base, and that's why we include those cores of the anterior fibromuscular stroma, which capture both its tissue as well as that of the anterior transition zone. And at the end of the case, it gets exported so that you could do 3D review of it. Here I've taken those cores off of the reference ultrasound and fused them back onto the MRI. And then later downstream, I could then use those exact same images for performing focal therapy. So, this is a case of a patient where the lesion was positive up here. I knew the boundaries because I knew the precise location of my other biopsy cores. And so then I was able to do focal therapy, this time in the OR, not in the office, to ablate that area. So that's how I do it. That's how I perform transperineal prostate biopsy in the office setting. And so, I believe my time is up. We'll have time for questions at the end.